broad topic. Hyman said
Are you calling Chris?
Yeah, I'm trying.
It might be with Ismail. He's doing.
Is this any better?
He's
Hold
doing
on.
the technical exam, so you'll be helping them with the administrative part.
Yes, I can hear now.
Can you hear now?
Yes.
Okay. Okay, I just plugged and unplugged the owl. Okay. All right. I'm gonna go back.
You have to do that because that was really, that was a really comprehensive explanation from the beginning. So they have to understand from the beginning.
Do you want me to go? Do you want me to start from the beginning?
I will.
Niku?
Well, the problem is I can't see anything now.
Oh, no. Well, I will. Just a second.
Oh, okay. No, I think you can just keep going because I was looking at the slides anyway.
Okay. All right, I'm going to start, just a moment. I'm going to start back here. 1 second. Thank you for letting me know it wasn't working. It's unfortunate, but that's such is life. Okay. Okay, can you see the screen?
Yes.
What I was saying is, as I was preparing for this talk, we talked just about why we don't use treatment routinely for with acid suppression, and the summary was there's very little evidence, that it actually makes any difference to meaningful outcomes. And when it comes to preterm infants, what you didn't hear is that other research has shown increased mortality rates in units that routinely use acid blockade. And then just as I was preparing for this, on November 15th, JAMA Pediatrics sent me this analysis of neurodevelopment in children born extremely preterm treated with acid suppressants before 2 years of age. This study came from, this came from the ELGAN study, which was sort of completed in the late 2000s, like 2007, 2008, 2009. It's a French study. And the claim to fame is it's probably the largest and longest cohort study looking at preterm infants who were less than 28 weeks at birth. So it was a prospective study, and they keep, if you were to look up, just in case you're interested, if you ever want to know about babies under 28 weeks, if you look up the ELGAN study, just in PubMed, you'll get hit after hit after hit. They keep putting studies out looking at what these kids were like, at age 2 and at age 5 and so forth. So one of the things that they were able to look at is they wanted to look at, for the 1,506 neonates, and by the way, that's a lot of neonates, right? So when we look at a lot of our studies, we're talking about groups of 100 or 50, so 1,506 under 28 weeks is pretty good. And they wanted to look at follow-up at 10 years for developmental assessment, so they had 899, so about half. And the exposure of interest was, did you have exposure to acid suppression in the first 2 years of life? Now, this was done by a parental questionnaire, so they don't have any, there's always room for error there. The error could be that they don't remember, or they didn't know the drug was actually acid suppression. And they didn't really quantify in this study for how long. So, if somebody was put on it a month, they weren't counted differently than somebody who was on it for an entire year. But this is what they found. And this is why I thought I would present it to you, because if you didn't feel that the lack of evidence was enough to curtail your practice, prior to this, these were the outcomes that were statistically different between the groups. So in the groups that had acid suppression, there were 486. There was a longer duration of ventilation. White matter disease was increased in those who had acid suppression. And finally, at 12 months, the incidence of feeding difficulties was about 6% higher, 26.5% versus 20.2%. One of the challenges with all of these studies is, and they did try to control for these to say that, they have adjusted to look for, confounders. But the question will always be with this study, did these kids get put on acid suppression because they couldn't be extubated, right?
Because they were sick.
Yeah, the sicker kids are more likely to get it. Now, the authors did control for these things. But I know that some people will still cast some doubt. But nonetheless, very interesting. One of the things, and now we get to the other thing being clinical versus statistical significance. So what they found when they looked at the 3 different measurements here, what they found was, here were the associations. Decreased full-scale IQ these are Z-scores, minus 0.29, and that equals about 4.4 IQ points. So not huge, the difference between 100 and 96, but I guess one could say if your IQ was, let's say, 87 in one group, and then the average was 83 in another group, you're classified differently. Reduced and nonverbal IQ are very similar, minor differences in Z-scores, minus 0.22, and reduced verbal IQ, minus 0.34. So what do we take from this? My colleague Hanifi was shaking his head because I know he was thinking the same as I, that, confounders, and which came first, the chicken or the egg. What I think I could say from this is there's nothing about this study that would lead me to want to treat with acid suppression, okay? The other thing that they found in this study was a relationship between autism spectrum disorder and the use of acid suppression. So I'll draw your attention to the bottom. If you had those kids with autism spectrum disorder and intellectual impairment was statistically significant. When they looked at the adjusted odds ratio, which is on the bottom right, you will see the ratio was about 2 times the risk to have intellectual impairment and autism spectrum disorder, and that was significant. Okay, so when you put it all together, the lack of evidence due to low numbers of RCTs, no benefits that have been demonstrated, and now a question that's being raised about whether or not the use of these medications is associated with a worse outcome. I would hope that you would agree that Choosing Wisely made the right call and by putting this on their website. But that's some of the evidence. So now we're going to move on to don't order a routine ultrasound for children with undescended testes. Now this one is interesting because I have to tell you, I think we do this. I think when we can't feel a palpable testy, what do? We often order an ultrasound and we say, let's find the testy, or testicle. Why did they say not to order a routine ultrasound? They said not to order a routine ultrasound because of this study. It's a systematic review. Many of the references that they use in Choosing Wisely are the results of systematic reviews. But this is, I was actually very surprised to see this because again, I think if I was to ask for a show of hands, I think a lot of people do go looking for that testicle if they can't palpate it. So this is the positive likelihood ratio. And you can see there's about 10 or 12 studies here that were done. And the positive likelihood ratio, the forest plot at the bottom there, that diamond at the bottom crosses 1. What that means is that if you do an ultrasound and you find, well, you believe you don't find the testy in the inguinal canal, it's not in the scrotum, and you believe it's in the abdomen. If they were actually to do a surgical exploration, they would find it's not that helpful. Okay, sometimes it would be in the abdomen, sometimes not. Okay? Similarly, look at the negative likelihood ratio. So you do a test, you look for the testicle, you don't find it, okay? It also crosses 1, meaning it's not helpful. Because the testicle, even if you didn't see it, might actually still be in the abdomen, okay? And this is, I think, the most powerful of the slides. This puts it into likelihood ratios. So just to bring this, to bring this around for you. So overall, if you look at studies on the use of children with cryptorchidism or undescended testes, the pre-test probability, if you don't feel a testicle or testes in the scrotum, The pre-test probability that it's in the abdomen is about 55%. It's a flip of a coin, okay? If you look at all the evidence, the red line is the positive likelihood ratio. The dashed red line is the 95th confidence interval for positive likelihood ratio. Similarly, the negative predictive value is the solid blue line, and the dashed line is the 95% confidence interval. So what this is saying to you is that on average, if you were to believe that you couldn't feel the testicle in the scrotum or in the inguinal canal, before you do this test, there's about a 55% chance that it's actually in the abdomen. If you do the test, that number only goes up to about 63, 64%. If you do the test and you find it's not in the abdomen, the likelihood that it's really not in the abdomen goes from 50% down to, on average, that's a straight line, 50%. It's not changed. So it's actually not a helpful test in ruling it out. Okay. So for this reason, the recommendation has been made not to do it, okay, and rather to wait and follow up the assessment. Because as we know, many of these testes are actually testicles, are probably high up in the inguinal canal and will eventually come down if you give it time. This would be another story, you know, before a year of age, you would need to document if it's still not down. But I guess the point is there really an urgency when these babies are in the NICU or when they're first newly born, if they're on the postpartum ward and you don't feel that there's a palpable testicle on one side, do you need to go chasing these with ultrasound? Choosing wisely would say no.
This is the only for unilateral, right? For the bilateral should be different story.
No, this is for, I believe, any. And so, yeah. So even if it was bilateral, I think what it comes down to is what are we worried about? What we're worried about is malignant transformation, right?
Or ambiguous genitalia.
I'm sorry?
Ambiguous genitalia.
Oh, absolutely, yeah. I mean, if it was bilateral and genitalia were ambiguous, you know, I would say yes, you would do an ultrasound. But in the presence of a normal formed phallus and clearly a scrotum, you know, that has rugae and so forth, but it's just empty. Yeah. You know, I wouldn't recommend doing the ultrasound. I think sometimes what this comes back to is it's our need to get an answer, right? And I found it interesting about that, you know, the negative predictive value is interesting. You know, that if you don't see it, there's still a 50% chance it's in the belly, right? But what's also interesting is the positive predictive value, it's about the same. If you do see it in the abdomen, you think you see the testicle in the abdomen, there's a 50% or at least a 40% chance that you're wrong. And so the argument is, and I guess it comes down to resource utilization. Yeah. You know, if you have lots and lots and lots of staff that can do lots of ultrasounds and you want to go looking for them, you can. But maybe you should save those ultrasound techs the time you get those head ultrasounds or get ultrasounds of abdomens for other purposes and not use them for a test that you really don't have a lot of confidence in, because what this is telling you is that even if you do it, and you tell the parents, oh yeah, no, we saw the testicle in the abdomen, there's about a 40% chance it's really not there. Yeah. Yeah, so it's not a great test. So now we're going to move on to the third one, which I found very interesting because there's a Canadian slant to it. So don't delay testing for total and conjugated direct bilirubin in any newborn with persistent jaundice beyond 2 weeks of age. What's interesting about this one is the quoted paper to make the argument that you should not wait more than 2 weeks is actually a Canadian reference. For those of you who have worked here for a while, I know it would be, Hanifi would remember the name, Rebecca certainly would remember the name. Stan Morose is there. I don't know if you remember, Stan Morose was one of the original gastroenterologists, the Pete's gastroenterologist. He worked alone for many years.
Here? Yeah,
here. So he was part of the Canadian Pediatric Hepatology Research Group that made this recommendation. This was based in large part, and I think it's important to disclose this, based on this Canadian survival curve. So what this shows you is the solid line is survival based on the time of the Kasai operation. So what this shows you is the solid line is less than 30 days for the Kasai. The dashed line is 31 to 90 days. And then the dotted line is more than 90 days. And what you see is probability of survival out past, let's say, the 120. 120 is 5-year survival, okay? So, sorry, that's not right. 10-year survival, sorry. If you look at 10-year survival, you're looking at about probably 20% if your Kasai was done after 90 days. That improves to maybe 27% if it's after a month, and it improves to 50% if it was done within 30 days. So what's interesting, because it just goes to show you, the strength of evidence. Okay? When I went through and I read the Canadian experience in preparation for this talk, they don't speak of actually any studies that looked at a 1-week screen, a 2-week screen, a 3-week screen, okay, looking to diagnose these patients. This was the recommendation for 2 weeks is purely a pragmatic approach based on the knowledge that, if they want to get the child into the operating room for a Kasai before the 30-day period, you really can't wait till 25 days and expect you can get them into the OR and do the Kasai and so forth. So they recommended anyone with persistent jaundice at 2 weeks of age, should, be screened for this. So I thought that this was very, interesting because I started to think about it. How often do we actually screen? Okay, like, do we screen? Hanifi's shaking his head no, right? So screening would imply that what you've done is you have, just like with newborn metabolic screening, that we would have a protocol in place where every baby, with a bilirubin that's elevated, let's say in the first 24, 48 hours, has a follow-up at 2 weeks with a direct bilirubin, making sure that we don't have, any problems there. Now that would be a lot of blood tests, right? But that's exactly what this very creative group did back in 2020. So this, I mentioned at the beginning, and I don't know if how much the people who couldn't hear me speak heard, but I mentioned that the goal of this talk was to take you through the studies. Like, I'll show you each of the studies that was used to make the Choosing Wisely recommendation, but then what I've tried to do is find additional studies that have come out since those recommendations came out that maybe add something, maybe it gives further strength. So this was another JAMA pediatric study, and what they wanted to do was they came up with a 2-stage screening protocol, and they did this was an observational study to determine whether or not they could pick up these cases of biliary atresia. So you can see they screened a phenomenal number of births. This is 125,000 births. There were 123,000 babies screened in stage 1. So stage 1 meant within 60 hours of life they had a bilirubin, and they had a direct. Okay? If that bilirubin was over, I believe, the 95th percentile, they were scheduled to have a 2-week follow-up. Okay? You can see that the majority of babies screened out after the first screen, but leaving 1,354 with positive screen. So you wind up with 1,334 retested in stage 2, and 119 out of the original 124,385 had an elevated bilirubin. So what does that mean? The screening definitions. So stage 1 was, as I mentioned, any baby in the first 60 hours of the bilirubin that was over the 95th percentile. This was a direct bilirubin. Stage 2 was if you tested positive in stage 1, then at the well child visit, you had a follow-up direct bilirubin done. And a positive test result was defined as either a direct bilirubin that was higher than the direct bilirubin within the first 60 hours, or a direct bilirubin at 2 weeks that was greater than 17 micromoles per liter. Okay. Which is really not that high when you think about it. We see a fair number of babies, you know, I think with certainly preterm infants with direct bilirubins, but these were term infants who were otherwise healthy. So the number of babies with a direct bilirubin at 2 weeks of age would be that should be very, very low.
So this is like a 60 hours total or just the direct bilirubin?
They looked at total and direct. Yeah.
The total and direct 60 hours.
But they were really interested in if your direct bilirubin was high.
Was high.
Yeah. And that's why, because when you think about it, we see a lot of babies with high bilirubins, you know?
Yeah.
Yeah, but this was direct. So kids with high direct bilirubins, and they screened them again at 2 weeks of age.
And they shouldn't get any phototherapy or something.
Whether they had phototherapy or not, as long as they qualified, they were followed up at 2 weeks of age.
Was co-founder like TPN ruled out like?
Well, these are all well babies, right?
Oh, okay.
So these are not NICU babies.
Oh.
Yeah.
But what did they find? Well, this may not shock you that this study did not prove to be the be-all and end-all answer. If it was, we would all be doing screening at 2 weeks of age. So what they found, and this is from figure 2, so it's the sensitivity and specificity analysis and negative, so I've shown it there on the right, but ultimately, here's how to summarize it. Those who had biliary atresia were likely to have a positive test. Okay, so if you have biliary atresia, your direct bilirubin will be elevated, most likely. Those who don't have biliary atresia are also likely not to have a positive test. Okay, so that's reassuring. Those who have a negative test, so now we're talking about predictive values, those who have a negative test are very unlikely to have biliary atresia. So the screening test was good in the sense that, you know, if you had a negative test, you could be fairly reassured your child does not have biliary atresia. The problem with the test was that those with a positive test were very unlikely to have, were unlikely, not very unlikely. There were a lot of babies who had a positive test who did not have biliary atresia. So the false positive rate was quite high. Okay, so the reason that you've not seen this test get adopted, because you can see that the positive predictive value is 5.9%. So when we think about doing tests, one of the things that Choosing Wisely, now Choosing Wisely didn't know about this study because this Choosing Wisely published years ago. But if you were to adopt this test for bilirubin screening, you would be screening a tremendous, there was over 1,000 babies that needed a 2-week blood test, right? And of those who are positive, the vast majority, 94%, would not have biliary atresia. And so probably not the right approach. The better approach would be, I think, is to be vigilant. So babies with persistent visual jaundice, you know, should have a direct bilirubin performed when they have their, you know, follow-up blood work. So, and that would be the recommendation. So for now, if a patient has persistent jaundice, and this is what they said, and this came right out of the study. Their recommendation was, for now, if a patient has persistent jaundice, don't delay ordering a direct bilirubin of 2 weeks or older. Okay. So interesting study, the idea of a screening test, but this is an example of a screening test that has too many false positives to put into regular practice. So now we're going to go on to the last Choosing Wisely statement. And by the way, Ismail, you can go and look. Choosing Wisely Canada is a website that has all sorts of recommendations to try to reduce needless testing with tests that don't have a good quality. So this one is sort of near and dear to our hearts because we're right in the midst of trying to move forward on a protocol or a standardized approach to resuscitation at 22, 23 weeks and so forth. But so don't give antenatal corticosteroid therapy unless the pregnant woman meets the gestational age criteria and the risk of delivery within the next 7 days is very high. Now, I learned something in preparation for this, which may or may not shock you, and I'll show you it on the next slide. But So antenatal steroids work best to protect the fetal lung 1 week after provision, okay? At least that's what we've been told, okay? If you heard Sarah McDonald's grand rounds in the last year, she's from McMaster University. She presented on the effects of multiple courses of antenatal steroids and suggested that in animal models, there have been adverse developmental effects in terms of brain structure, size of the brain. There's now some literature coming out about perhaps babies exposed to multiple doses of steroids could have smaller brains as well. And what motivated the discouraging of multiple courses of steroids initially was this study, the MAX study, which you may have heard of, which was a multiple antenatal corticosteroid study. And essentially what they showed, and I'll just read it out to you, this was from 2013. What they showed was multiple courses compared to the single course of antenatal corticosteroid therapy did not increase or decrease the risk of death or disability at 5 years of age. Because of a lack of strong conclusive evidence of short-term or long-term benefits, it remains our opinion that multiple courses not be recommended in women with ongoing risk of preterm birth. Now, as I read that out to you, you probably say, but wait, you sent out a memo, well, it's before many of you were here, like 5, 6 years ago, advocating for a second rescue course, okay?
Possible course, what do you mean? Like,
well, we'll talk about that in a minute. Yeah, so in Manitoba, we did an audit about 5, 6 years ago, and we looked at the number of women that were getting complete antenatal steroid courses prior to delivery. The number was low. John Byer and I looked at it, and the number was very low. And the reason it was low, we discovered, and talking to the obstetricians, was that in Winnipeg, and you would know this, we receive many babies, or many women are transferred in from rural places. And what the obstetricians were doing was, because they knew they could only give 1 course of antenatal steroids at the time, they said, you know what? If Dauphin called and said, we have a woman who's contracting, they'd say, well, send her in. And so, you know, by the time the plane got out there and she made it to Winnipeg, sometimes she wasn't in labor at all, but other times, what was a woman who was 3 centimeters in, you know, Dauphin was now 9 centimeters by the time she got to Winnipeg, and she went on to deliver without steroids. So what we said was, we said, you know what, based on what we knew, there really doesn't appear to be any evidence at the time that a second rescue course is detrimental. We knew that steroids are supposed to be good within 7 days, or best within 7 days. And so we made an argument that it made sense to just give the women the benefit of the doubt. If they present, start the steroids in the referring center. If they get to Winnipeg and they're not in labor, they can always have a second course. Now, we said after 2 weeks after the previous one. So that's sort of been our current practice. The statement from the SOGC, and this is one of the things I learned this week. So the statement from the SOGC, which is number 364, was originally published back in 2013, I think, or 2003, sorry. It was reaffirmed in 2018. There's a Winnipeg member on here, Savas Mentakoglu was a high-risk obstetrician who worked on this statement. And what this statement said was to give steroids, as you'll soon see, to 24 weeks to 34 and 6. Okay. What I thought was interesting in preparation for this talk, I said, but wait a second. I said, you know, I'm pretty sure that the SOGC has now come out and said that, you know, steroids can be given to 22-weekers, 23-weekers. And so I reached out to Vanessa Poliquin, who's the head of obstetrics, and I said, do you have access to a newer statement on the use of antenatal corticosteroids? And then she looked into it and she said, actually, that is the latest statement. So the CPS has moved forward and said to give at 22, 23 weeks, but the official statement on the SOGC website remains to give for 24 weeks to 34 and 6. The AAP, or sorry, the ACOG, the American College of Obstetricians and Gynecologists, I believe, has now said at least 23 weeks. But anyway, that's just interesting that SOGC has taken that position. And again, they say antenatal corticosteroids should be administered to women at risk of delivery prior to 24 weeks when delivery is expected within 7 days and you're planning intensive care. So that would really be a 23-week or and above. So they're allowing for 23, but certainly not 22. And they say the routine use of rescue or repeated courses, that's what we're doing, is not recommended. I take issue with that statement because one of the things that becomes a problem for Manitoba in particular, in case you didn't realize it, our catchment area is probably the biggest in the country. It's very easy if you're in Ottawa or Toronto, even Calgary, where you can have a woman who you're wondering about labor to you within 15 minutes to an hour. Very different if it's a 4-hour transport, and you don't know whether they're in labor or not. So they're saying they don't recommend a repeat course, but certainly in our jurisdiction, we have to consider risk of not giving steroids at all. One of the things that was funny in preparation for this talk is I kept seeing everywhere it said we recommend steroids, and Choosing Wisely says we recommend steroids, antenatal corticosteroids have a maximal benefit within a week. Okay? And the quote, or the paper that was quoted to demonstrate that effect is this one from the Cochrane Library that was published in 2017. Now, Ismail, you've got a better eye than me perhaps, but I went through this statement in preparation for this. I can't find that anywhere in the statement. The evidence within this review that steroids work best within a week. Having said that, it does make sense that, like sometimes you don't need a randomized controlled study to tell you that it's most likely that soon after you give a drug is when it's most likely to have a benefit. But as far as that limitation of benefit to a week, I don't know where that actually comes from because I can't find it in this. But if you go to Choosing Wisely Canada, they reference that 7-day period as this. Okay. Now, what about the CPS? This is near and dear to my heart. I was on the committee when we wrote this statement. I'm still on the committee, but this statement is from 2017. The lead author is Bridget Lemaire, who's in Ottawa. And what they said in this statement is antenatal corticosteroids should be given to women who are at greater than or equal to 22 weeks gestational age, when early intensive care is a management option. Okay. And so what that is addressing, is the concept that, if for example, that a mother and father or parents have already said no to resuscitation before 23 weeks, why expose the fetus to steroids? Okay. If they say we don't want resuscitation until 24 weeks, or what if they live in a rural place that only has a level 1 or a level 2 hospital, and they said we've got multiple children, we're not prepared to leave our community until after 24 weeks. Well, there's no point in bringing them down if they can't offer intensive care where they're going to be. So I thought this was interesting. This came out in 2000, I don't have the date, I thought I did, 2021. So in 2013, the MAX study came out showing that there really didn't seem to be any benefit to multiple courses of steroids. This study, which is an individual participant data meta-analysis, this study came out in 2021, and I think it's actually very interesting. Now, just to remind you what an individual participant data meta-analysis means, okay, because maybe not everybody knows what this means. You've heard of a meta-analysis. Meta-analysis is where you take all these studies and that are similar, and you pool them together, okay? And then you say, what's the result? Now, in an individual patient data meta-analysis, what you actually do is you go back and you get the original research records, all the data from the institutions that did these studies, and you say, let's reinvent the wheel. We can now ask questions that were never published. We can look at the original data and we can put all the data together and ask some additional questions. Okay, so that's what an individual patient data meta-analysis is. And so what do they find? So who are the patients? So when you go through, what's pretty impressive about this study, I'll tell you the positive and I'll tell you the negative. I mean, I love studies where there's thousands of patients because it does certainly increase the strength of the recommendation, you know, if there's many, many patients. So when they looked at, you know, I've included the diagram from figure 1 in the study, which shows you that ultimately they looked at 11 studies to include in the individual patient data meta-analysis, that's the IPD. So they started off with 5,893 babies, and they were looking at use of respiratory support. They were looking at measurements that could be affected by steroids. So, for example, birth weight. Okay, and then ultimately they were able to say, okay, we've got 11 studies we can look at serious outcomes. We've got 6 studies we can look at for death or any neurosensory disability, and then we can also look at maternal sepsis in 11 studies. Now, if Molly, maybe Molly is here, but Molly is always the one who points out there were very few babies under 27 weeks, right? So in this study, the same thing applies. Very few babies were under 27 weeks. The majority of the babies in the included 11 studies were between 27 and 30 weeks. It doesn't mean there weren't any, it's just the majority were between 27 and 30. So we do have to reserve a little bit of caution in saying what we would recommend at under 27. And in these studies, there were anywhere from 2 to 5 courses of betamethasone given. All right, so does it work?
5 courses?
I've never used 5 courses, but I'm just saying in the studies, up to 5 courses could have been used. So when you look, just because they're small, when you look at the first primary outcome, which was a serious outcome was a composite of things like PBL, bad IVH, BPD, sepsis, those sort of, like, we've seen those composite outcomes before death. When you looked at it, the provision of multiple courses of antenatal steroids from 2 to 5, the number again crosses 1. So it means that whether you use 1 course, whether you use multiple courses, you don't have any impact on a composite outcome of multiple issues. When you look at figure 3, the right figure, they're looking at respiratory support. Interestingly, they did find a difference. Okay, so, and this is the reason why we actually give multiple courses. We give a rescue course, because our argument was that if you have a woman present at 24 weeks and she doesn't go on to deliver, and 3 weeks go by, she's now 28 weeks, let's say, we want to give her a course of steroids because we think we'll have a greater chance of keeping her off the ventilator. And that's what the study actually found. Multiple courses of steroids had a reduction, so a cumulative reduction of, the point estimate was, the relative risk reduction was 91, so 9% improvement in the likelihood that you're not going to intubate the baby, okay? Of course, the 95% confidence interval around there was as much as 15%, but as small as 3%. But it's a difference. So we will see a benefit in reduction in need of respiratory support. When you look at neurosensory disability, it doesn't make a difference. Now, this is important, okay? So this individual patient data meta-analysis has reported that when you combine all these studies, and some of them are multiple exposures, so we would think that multiple exposures, 2, 3, 4, 5, or more exposures to steroids could stunt brain growth, it could interfere with the development of pathways. But ultimately what they found was when you look at childhood, there does not seem to be any impact from these multiple doses of steroids. Now, what about measurements? Okay, so I tried to simplify this, but what this is showing is that birth weight Z scores were lower in those who had multiple courses of steroids. Now, what does it mean? It wasn't significant, but it was minus 0.12. Okay, so even if you say there's a trend, a Z score of minus 0.12 is a very negligible difference. lower head circumference and with 2 or more courses. Okay, but again, it was a very, very small difference. So what was the difference? So if you look at head circumference at birth, 0 would be your, standard, okay? If you had 1 course of steroids, there was a reduction of 0.07 Z-score from that. If you had 2 to 3 courses of steroids, minus 0.16 for head circumference. So you will see a mild reduction in head circumference, but that does not appear to translate into any neurosensory disability down the road. So best guess is that they would catch up. Where you do see some significant impacts is with many courses of steroids. So certainly when we look at the choosing wisely statement about giving steroids within 1 week of anticipated preterm birth, it fits, it makes sense. In our institution, if we wanted to give a rescue course, there does not appear to be any pooled risk for neurosensory impairment, but there is an improvement in respiratory support. And so that is the end of the talk. Does anyone know who that, does anyone know what the reference is there? Does anyone remember that man? Okay. This is probably a cultural reference. He is from Indiana Jones and the Last Crusade. This is the, he is one of the people who was tasked with protecting the Holy Grail. Did you ever see that, Indiana Jones, the Holy Grail? And he's one of the soldiers that is staying there for eternity protecting it. Anyway, that's the and he literally says when he has to pick from the cup, he has to choose which cup to drink from. The right one is the Holy Grail. And the words that he says is choose wisely. Because you die if you pick the wrong one. Anyway, let's see. Are there any questions? Oh, Addie?
Yeah. Well, it's a little bit like more of a digression a little bit, but is there anything on Choose Wisely Canada regarding the resuscitation of 22-weekers, considering their, then I don't know, is there, what informs or is there evidence-based information about resuscitating less than 22 weekers? And
less than 22?
Short term, 22 and below.
Right.
Or 22, the new trend, what I mean is resuscitating 22 to 23 weekers, considering their short-term complications and even the long-term complications. What really informs going?
So I mean, there's no, so the question, everyone, just in case you didn't hear, sorry, I'm distracted. My mom has something jiggling in his field.
Yeah, he's in the car.
Oh, he's in the car.
Yeah,
the question is, does Choosing Wisely have a statement about the resuscitation of 22 and 23 weekers? And the answer is no. I will make a broadcast for the Canadian Pediatric Society, not just because I reviewed the statement on the committee and agree with it, but I think that the current statement that we have with the CPS really goes a long way to addressing a lot of the uncertainty around the resuscitation at 22 and 23 weeks. And just to summarize what it suggests is, there's a few guiding principles. Number one, survival is better than people generally anticipate. Okay? It's not great, but it's, people would say there's no hope, but that's not true. The survival at 22 is around 40% in Canada. The second thing that I think is important is that when you look systematically at parental and patient perception of quality of life when they're teenagers or when they're adults, they view it very differently than we do. Okay? Probably the reason for that is that it's the lens through which you are viewing. So if you've never known anything different, let's say you've got an IQ of 82, but you struggled through school, but it's what you've known all your life. It's normal for you, right? So you don't rate your quality of life as low as, let's say, I would. if I look at that life and I say, that's not very good, right? So we know that that's the case. And one of the things that would be very useful for everyone is you can probably watch for free. Have you ever heard of Preemie Voices? Yeah. So Preemie Voices was a program, it's a video created by Saroj Singhal. Rebecca, you've met her, I presume. Have you met Saroj? Yes, no? Anyway, Saroj Singhal is a neonatologist who I think has been in practice for 50 years at McMaster. And she wrote a book and she interviewed families and patients, former preterm infants as adults, about their lives. And it's really remarkable. I mean, and she interviewed people who were impaired, who weren't impaired, with cerebral palsy, and she looked at what happened to them 20, 30 years later and how their lives were going, and it's really eye-opening, you know. And then the last thing, I mean, this is a talk unto itself, and I've given that talk on 22 weeks, but the other thing that the CPS really advocates for is that the decisions are not made in a paternalistic way, but that it's a shared decision model. Now, shared decision model is difficult because basically what it says is, it is our duty to inform parents with accurate data, the best data we have, what the outcomes are, and explore their values and what's important to them, their background, and then ultimately support them in a decision, right? That's sort of where we land on this. So choosing wisely certainly doesn't have anything on this, but I would say the CPS in its place has made a statement about that. Hamam, you have a question or a statement?
Thank you for the impressive talk. I wish I was there in person. I just made it to HSC. After arriving to the lot, I have to go back home quickly and come back. I know this is more of about, again, I appreciate your lectures and how you bring out history and, you know, where we stand at now. This might be maybe a pharmaceutical question. How late can be steroids given antenatally and still be effective? The reason I ask is because the OB-GYN was to deliver a baby within 4 hours. I'm like, oh, it's useless now. So I looked up literature. A lot of them kind of talked about 12 hours. But again, I don't know if you had insight on that.
I too have come across 12 hours as a common number that people come up with. My argument would be just give them, because one never knows how long it will actually be. So I've had the situation, in fact, I just had the situation at St. B not that long ago, where they said, well, I was with you when, you know, you called me at like 8 in the morning to say this mother's delivering, right? And, you know, you probably come in. And she didn't, we lost them. The mother actually didn't go on to deliver until 3 or something in the morning. So her labor kind of stalled. So the point being that if we had said, well, we'd already given steroids in that case, but let's say we hadn't. And we said, well, let's not give steroids because we're not going to have a long enough window, then you wasted it. I mean, you wasted an opportunity. So much like we talk about, or I shared with you that my recommendation whenever I get a call from the periphery is just give the steroids and then we'll worry about it later, about maybe repeating a course. It's better to be safe than sorry and just give them, because you don't know whether it'd be 4 hours, 6 hours, 8 hours. But I think I agree with Hamam. The best data I've seen is that generally 12 hours is needed to get an effect.
So this, I don't know, like I cannot see it here as a practice, but we were discussing in Turkey about the recommendation to give steroids for elective C-sections, 34 to 36-week babies. I think there is no this kind of discussion in Canada at the moment, right?
Not true. So about 5 years ago, I presented this multiple times. You weren't here. It's not your fault. But I actually have a presentation on antenatal steroids at 34 to 34 and 6, 35 to 35 and 6, and 36 to 6 to 37. So when you look at the pooled evidence, it works. The problem is in the numbers needed to treat. By the time you get to the 35 and the 36 weekers, you know, certainly for 36 weekers, I think you had to give beta to like hundreds of women to actually avoid one, you know, bad outcome. At 35 weeks, the number I think was more in the line of like 80 to 1. And at 34 weeks was probably about 20 to 1. And that's the reason why the SOGC has suggested up to 34 and 6. There's a benefit, right? There's been, you know, like Sarah McDonald, like I mentioned, when she came and presented Grand Round, she painted a very negative picture of giving steroids, if you heard her talk, with, you know, reductions in head circumference, reductions in, you know, brain development and so forth. But again, I look back at this individual patient analysis and I say, well, all of that may be true, but it does not translate into actual impairment. But it does translate into a reduction in respiratory need. So I think you'll probably see now that most of our obstetricians are now giving steroids if it's a section at 34 to 35 weeks.
Okay.
Yeah. I see we're 5 minutes over. Sorry, Iman, we went long. Is there another session for the fellows now?
Yeah.
12.
At 12. Okay. Are there any other questions then? Doesn't sound like it. All right. Thanks, everyone. I'm giving your fellows a break so they can eat something.
Thanks,
it's
Mike.
about work-life balance. Okay, take care.